would like to present Dr. Sudhir Kumar, who's a consultant neurologist at Sheikh Shakhbut Medical City. He's going to tell us today how to perform a neurologic exam.
Greetings, everyone. I'd like to welcome you all to our third annual Neurology for Primary Care Conference. Today we have with us Dr. Sudhir Kumar, who is a neurology specialist at Sheikh Shakhbut Medical City. And with us we have Mr. Santosh Kumar, who is our volunteer who has kindly agreed to be our participant on how to perform a neurologic exam. Without further ado, the virtual floor is yours, Dr. Kumar.
Thank you, Dr. Shatila, for the nice introduction. And thank you, Mr. Santosh, for volunteering today. Well, neurological examination in everyday practice can be difficult, especially for a non-trained person. We all knew from the undergraduate days that the examination of neurology can be either a 30-minute piece or it could be a 5-minute piece when somebody is really an expert and who does it every day. It is like doing our everyday brushing of the teeth. You don't know how you do the brushing, but the idea is to have a normal, clean teeth. It becomes a second nature to us. So the same way, the neurological examination has to be a second nature to us, and we need to practice it every day. Having said that, we need to kind of tailor the neurological examination as per the scenario as and when the patient comes into the clinic. So the real neurological examination starts as soon as the patient enters the clinic. As he enters the clinic, you look at the way he is swinging the hands, moving the legs. As you know, a person with Parkinson's will not have the proper hand swinging, or somebody with hemiplegia can have a hemiplegic gait, or somebody with a tremor can have a tremor as they walk in. So that will give us some clue regarding the kind of neurological illness a person can have. For example, somebody with a ptosis, as he enters, we know that, oh, he has a ptosis means we have a differential from that point itself. So you need to keep your eyes open, ears open, and all your senses should be on the go all the time. So as the patient comes and starts talking, the neurological examination, as the classical teaching, it is compartmentalized into different modes, starting with the higher mental functions, the cranial nerves, the motor system, the sensory system, the cerebellum and the coordination system, as well as the skull, spine, and the vasculature, the carotids and the peripheral vascular system. And finally, the gait and including Rhombox. So all these segments are done in a shorter way, the way you do it every day, but then you document it in the classical way. So depending upon the scenario, you change the clinical examination order, but you come to the same conclusion. As you do the tests, you improvise depending upon the situation in which the patient and yourself are in. So that is the most important thing. So the higher mental function starts with, as you talk to the patient, whether he is oriented. I mean, if he is coming with somebody and if he is on a wheelchair or if he is on a couch, then maybe if he is not conscious, you need to know whether the person is conscious or not. If the patient is conscious, if he is alert, he is oriented to person, time and place, and whether he is oriented to know why he is here in the clinic that day. So this will give you a rough idea about the higher mental function of the patient. And as you talk to the person, you will know more about the person in detail, like the more details, like what is the mood, what is the affect, and what is the thought content. These are all as you talk to this patient, depending upon the kind of cases you have. Now, once you are done with the preliminary talking and taking history, you are done with the higher mental functions. But same time, as you speak to him, you will know whether the patient has dysarthria or he has got a deviation of the mouth to one side. So if he has got any kind of abnormal involuntary movements, all this you record in your mind as you speak and see the patient. Now, as you are done with the higher mental function, we will go to the next examination, and that is the cranial nerve examination. So the cranial nerve examination starts with the first cranial nerve up to the 12th cranial nerve. And you all remember from your medical college days, remembering the cranial nerves, it was a tough item for us in the first year, and subsequently, as you progressed in your course, we all learned them by heart and by practice. So the first cranial nerve, as you all know, is the olfactory nerve, which is for the smell. Generally, previously, when during our residency times, the smell was not an important component at all. But with the advent of the new theories on Parkinson's, that there can be loss of smell, as well as with the recent COVID, where they lose their ability to smell. We do a cursory smell test. We are not ENT people, so what we do is we will just take a little bit of this powder and we will ask Mr. Santosh, what smell do you have?
Coffee smell.
Very good. So coffee is the one that we use generally just to make sure that whether the person has this smell sensation or not. So that finishes the first cranial nerve. Then we have the second cranial nerve, the optic nerve. So the optic nerve, we test simple things. Can you just close one eye like this, Santosh? Okay. How many numbers?
2. 1.
Right. Can you do the other eye now? Okay. How many fingers?
2. 1.
Okay. So that is for the near vision. Can you tell me the time now?
3:30.
Okay. So this way we test the distant and near vision. So the other thing that we do is we can quickly look at the direct and consensual light reflex. So what you do is you take a light source, fix the eye, ask the patient to look straight, and you look at the eye. Look for direct light reflex and you check for the consensual on the other side. Direct, look straight. Okay. So this is about the direct and consensual light reflex. Then for the accommodation, you ask the patient to look at the distance and then ask him to look at the tip of the nose. So because you will not be able to see the eye properly, what you can do is you can pull the eyelids up, look here and look here. Okay. So this is how you look for the accommodation reflex. Of course, if you are able to use an ophthalmoscope and if you are trained, you can look at the fundus using the ophthalmoscope. But then for a routine general practitioner clinical examination, fundus examination is not required. So after the fundus examination, the last one is the visual field examination. Again, in a clinic, you don't have to be very, very detailed neurological examination, but gross field examination. So what you do is you ask the patient to look at your eyes. You stand at about two hand length, and you ask him to look at your nose, and you ask him to indicate which side you are moving the finger. Which side now moving, Santosh? Good. Now which side?
This side.
Now?
2 sides.
Now?
No.
Which one?
This one.
Okay. Now?
This one.
Okay. Now?
This one.
Now?
This one.
Okay. So this is the gross way of looking at the visual fields. So that finishes the second cranial nerve. Now we will check the 3, 4, 6 cranial nerves. The first and second cranial nerves are supposed to be in the cerebral cortex. Now we are checking 3, 4, 6. 3 and 4 are in the midbrain, while the 6 is in the pons. So 3, 4, 6 is for the extraocular movements. We were taught too many movements, but then we need to do only minimum movements to check for the cranial nerves. I will show you how. You fix the head here and keep your finger at least 30 centimeters away. Ask the patient to look at the hand. This way, right now you are testing the third and the sixth cranial nerves. On third on the left side, right side, and the sixth on the left. Now the third on the left and the sixth cranial nerve on the right. So once you are done, you pull the eyelid up and you are checking now for the fourth cranial nerve. The function is intorsion. So you ask the patient to look like this. Right now you are testing the right fourth cranial nerve. Now you are testing the left cranial nerve, fourth cranial nerve. So this way you have tested 3, 4, 6. Though conventionally you have been asked to teach, so if you are learned this way, you can do this way. That is, look here, up and down. Now this way, this way, this way, this way, crisscross. So these are the ways you can test. Also, as you look at the eye movements, you are testing for the pursuit movements also. And for the saccade movements, what you do is ask the patient to look where the sound is from.
This side. This side.
So you are looking the way the quick movement of the eye is. So as we do the saccade, that finishes the 3, 4, 6 examination. Now we are going to test the 5th cranial nerve. It has got a motor and sensory part, but then the inspection itself will tell you whether the motor part is normal. So you look at the temporalis and the masseter muscles, and you keep both the fingers on either side of the angle of the jaw and ask the patient to clench. Can you just clench your teeth, Santosh? Very good. And you see movement of the masseter muscles on both sides. And the other two muscles are the pterygoids, medial and lateral pterygoids. So what you do is you keep your hand here, you keep the other finger here, ask the patient to open the mouth. Open the mouth? Okay, good. So the mouth opens centrally. So when the mouth opens centrally, you know that both the lateral and medial pterygoids on both sides are acting normally. So this is the quick way of testing the motor part of the trigeminal nerve. The other is you just test quickly for the sensation part. This is for the ophthalmic, this is maxillary, and this is the mandibular part. Mind you, the angle of the jaw is C2, so you need to be a little bit more medial than more lateral. So can you feel this, Santosh?
Yes.
Can you feel this?
Yes.
Can you feel this?
Yes.
Can you feel this? Can you feel this? Can you feel this? All are same?
Yes.
Okay. So this is in short, quick way of testing the motor part of the motor and sensory part of the 5th cranial nerve. Although we have, if we have time, we have other tests that we can do. For example, we can do the jaw jerk. We can look for the corneal reflex, where the afferent is by the 5th and the efferent is by the 7th cranial nerve. So for a quick examination, this is all you need to do. So the 7th cranial nerve, mainly we are testing the motor part of it. As you look at the face, the facial symmetry will tell you whether the facial motor part is normal or not. So quickly, the way you do is, can you lift your, yeah, okay. So when he lifts the frontal forehead, the frontalis is acting. Now, can you close your eyes? This is for the orbicularis oculi. Now, can you just blow like this? That's for the buccinator. Then that is for the orbicularis oris. So that will finish this, the motor part of the facial nerve. Now what we have is the sensory part, which is the taste, anterior 2/3 of the tongue. Only if there is a definite reason for checking the facial nerve, like for example in Bell's palsy, you don't have to really test the taste. You can ask the patient and finish it off at that point. Now we need to test the 8th cranial nerve or the vestibulocochlear nerve. So the easiest way is you rub your hands and ask the patient whether he can hear or not. So that's the simplest way. Can you hear this?
Yes. Yes.
Can you hear this?
Yes.
So this is the easiest way. Though vestibulocochlear has got the cochlear part and the vestibular part, one is for the hearing and the other is for the balance. The balance will be tested during the gait and the rest of the examination, including the motor. Now we are going to test the 9th, 10th cranial nerves. As you know, 9th, 10, 11, 12, they are part of the medulla oblongata. So the upper medulla is 9 and 10. And the easiest way is to ask the patient to open his mouth and say ha, and you look for the palatal movement. In a normal person, there will be single upward movement like a curtain. Can you please open your mouth? Put your tongue out, Santosh. Ideally, you can use a tongue depressor, but in a clinic, it will take time. So what you can do is say ha.
Ha.
Okay. So you look for the movement. Now we will be testing the 11th cranial nerve or the axillary nerve. It has got two muscles mainly. One is the trapezius. Can you shrug like this? Shrug up. Okay. And the other is the sternocleidomastoid. What you can do is you ask the patient to press your hand. Press your hand, Santosh. Like this. Okay. Or you can do this way. Can you press this way? This way, please. And you feel the muscle.
Yes.
This way. Feel the muscle, sternocleidomastoid. So these are the two ways of testing the 11th cranial nerve. The last and the final cranial nerve is the 12th cranial nerve. What you do is you ask the patient to open his mouth and not to put out the tongue in front. He has to keep it inside the mouth and look for any fasciculation or wasting. Can you please open your mouth? Just keep it inside and you look for any movement or fasciculation. And once it is done, you do the motor part. Can you do like this? You feel the tongue here You feel the tongue here. So this way you test the 12th cranial nerve. Quick examination of the motor system actually has started, as I said earlier, as the patient comes into the clinic itself. The way he moves, you can get an assessment of the power and the tone of the patient as he comes and sits in your clinic. So if you want to do more detailed clinical examination, then we need to go in a neuromyoterminal examination pattern. So I'll quickly show you how we do the neuromyoterminal pattern of examination for the motor system. So the motor system, you are looking at the bulk, whether there is any hypertrophy or wasting, or is it normal. If there is any abnormal movements like fasciculation or any tremors or any involuntary movements. And you can also look for any scars of previous surgeries or any shortening, limb shortening. So that will give you a roughly idea. As in any other clinical examination, inspection carries a lot more importance in neurology, especially the motor part of it. So once you do that inspection part of it, then you are looking for the tone of the muscles. So the rough way to look for the tone is the passive examination of the upper limb and the lower limb. So passive examination of the upper limb, how you do is, you do the antagonist and agonist group of muscles. You can either do it this way, just relax. Patient has not, we have to do by ourselves, relax, or it could be pronation, supination, or it could be flexion extension in the upper limb. Same way we can do in the lower limb as well. Now, once you do the bulk, the tone, then we are checking the power. While we check the power, it's an active movement, and as you do, you are looking at the, as I said earlier, the neuromyoterminal pattern. So I'll tell you how we do it and how we make the correlation with which part of the nervous system is involved. So can you push it up, forward, up? Okay, good. Push up. So this is C5. Okay, pull towards you. This is C6. Pull towards you. C6. Push towards me. C7. Push towards me. C7. Now cock it up. C7. Cock it up. C7. Cock it up. C7. Cock it up. C7. And hold my fingers tight. C8 T1. Hold my fingers tight. C8 T1. So this roughly is the upper limb power examination. So the last thing is the C8 T1. You ask the patient to hold your fingers tight, good, and tight, good. So that finishes the motor system power examination, the upper limbs. Now we will test the lower limbs. So it starts with the L12, cock it up. Okay, cock it up. L34, push my hand, good. Push my hand, okay, that is L34. Now cock it up. This is L5. Okay, L5. Push my hand down, S1, down, S1. Pull towards you, okay, pull towards you. And finally, push down, down, push down, down. So that is L5, S1. So this is a rough way of neuromyoterminal examination of the lower limbs. You can also actually test roughly the lower limbs by making the patient walk during the gait examination. I will tell you that also. So you can either use this method or the other method. The final part of the motor system examination, as you know, is the reflexes. So that too, the deep tendon reflexes, which are the important ones. So we start by exposing the muscle that we are going to do. So for example, here it's the biceps. So you palpate the tendon, keep the limb relaxed, and look for the contraction of the muscle. So this is C5. Supinator, this is C6, and triceps for C7. So you can compare on both sides. So this is for the upper limb reflexes, C5, C6, C7. Now in the lower limbs, ideally we need to expose the muscle that we are looking for the contraction. So the knee jerk is L34, you palpate the tendon, percus, and you look for the contraction of the muscle, or you feel for the contraction of the muscle. Okay. Now the ankle jerk, you palpate the tendon, stretch it, and hit it. The movement down, but the contraction is what you need to look for. So that is S1. Once the motor system is done, we will quickly check the sensations. Now again, mind you, in the clinic, we don't have to go to the details of the various sensations like pain, temperature, touch, or the vibration sense, the joint position sense. What you do is you roughly touch. Can you feel this, Santosh?
Yes.
Can you feel this, Santosh?
Yes.
Can you feel this, Santosh?
Yes.
Can you feel this? Suppose, for example, if the patient has a particular pattern of sensory loss, then you go into the details of a particular sensory loss. For example, if somebody has got a carpal tunnel, for example, you will be looking for the 3.5, 1.5 split of sensation loss in the palms. So depending upon the clinical scenario, you do specific sensory system examination, but always compare with the normal, abnormal. And this is the way you check for sensations. Now, the cerebellar system, there are 5 tests that we can do quickly. As you all know, the first one is to looking for the nystagmus. And as you have tested the external ocular movements, you have already looked for nystagmus. But roughly, this is how you do it. You ask the patient to follow your finger, look for involuntary movements of the eyeball, either horizontal or vertical or rotary. So this is how the nystagmus is tested. And the upper limb, you can look for 2 tests. The classical one is the finger nose test. What you do is you ask the patient to touch your finger or any object and ask him to touch his nose. So can you touch my finger and touch your nose? Good. Can you touch my finger and your nose? Okay. Now with the other hand, can you touch my finger? So this is the classical finger nose test by which you look for any dysmetria. And mind you, if there is patient has got dysmetria, you need to be careful with asking the patient to touch the nose because he can go and point to the eyes. So that you have to be very careful about. The other one is dysdiadochokinesia or the rapid alternating movements. The easy one is you can ask the patient to do like this. Can you do like this quickly too? Yeah, this is the easiest way to look for. Or you can ask the patient to screw an imaginary screw. Can you do like this quickly? So this is how you test the cerebellum in the upper limb. Now the lower limb cerebellar testing, the classical one is the heel knee test, wherein can you put the heel here and push down? Good. One more time. Can you do it on the other side? So this way you can test the dysmetria. Now the other test is called the tap test. Can you just tap like this? Quickly. Okay, good. On the other. So this is again the rapid alternating movements. So this is the way you can test cerebellum very quickly in the clinic. Now what is left is examination of the vascular system, which has an effect on the neurological system. For example, you need to auscultate for the carotids, you need to auscultate for any bruit or the eyes, or you need to palpate for the pulses in the lower limbs as well as in the upper limbs. So that finishes the vascular part of the examination for neurological system. And once you are done with that, you need to palpate the skull for any deposits or any defects. Also palpate the spine for any steps or any bulges or anything. So ideally, you need to examine for any congenital malformations, especially in the lower lumbar regions. Now the test is the Rhombox test for the posterior column. What you do is you ask the patient to stand up. Can you please stand up, Santosh? Keep both feet together and keep both hands together and make sure that you protect the patient properly, and then ask the patient to close the eyes. Can you please close your eyes, Santosh? Okay. So he is able to hold on. So this Rhombox test is negative. If the posterior column is involved, patient immediately falls. Now the final component is the examination of the gait. So what you do is you ask the patient to walk on one foot after the other. So this is how you ask the patient to walk on a straight line. And you can turn and walk this way. So this is for the straight line walking. And as I told you before, for the lower limb testing, you can also ask the patient to check the power this way. So you can either ask the patient to walk on his heels like this. This will test the L5, or they can walk on his toes for the S1 power.